hear us and see the screen. Hello everyone, and welcome to the webinar on improving clinical outcomes in onychomycosis using Lunula Laser. Thank you all for taking time off from your busy schedule this morning to attend the webinar session. My name is Harish Mithra from RehaCare Australia. At RehaCare, we have been working with Erchonia, the manufacturer of Lunula Laser, since 2015. I'm pleased to welcome Dr. Richard Silverstein. He'll be sharing his valuable knowledge and experience on this subject. Currently, Richard is working at Harvard Memorial Hospital, Harvard E. Grace, Maryland, as a division head, Department of Podiatry. He also runs a private practice. We expect to run this session for about 45 minutes. At the end, there will be an opportunity to answer any questions that you may have. Please feel free to ask questions throughout the session using the question Q&A button on the bottom of your screen. Without taking too much of your time, I will now hand it over to Richard. Once again, welcome. Over to you, Richard.
Thank you, Harish. I appreciate the opportunity to speak to you all. I know you guys are, I guess, 14 hours ahead. So we are Wednesday evening at about 8 o'clock. So you guys are Thursday morning. I appreciate you tuning in. I know what a busy day it can be with patients and issues and a pandemic. So we're going to get right to it. And we're going to talk about the Lunula Laser, which I've had personal experience with, not only in using it in my private practice, but doing clinical trials for Erchonia and getting 510(k) approval, which is our US governance on getting medical devices cleared for use in practice. So without further ado, we will get this webinar underway. So again, today we're going to be talking about Erchonia's Lunula Laser to treat onychomycosis. This is my office address, my phone number, cell phone. I know Harish will be allowing you to watch this probably as recorded, and you can probably get copies of the slides. I encourage you to take down my cell phone number if you want to call me, and my email address, and I always respond for clinical questions. I really enjoy sharing the knowledge that I've acquired because I like treating patients with the full gamut that we have at our disposal, not just pills or topicals, but anything that will work. So I'm always interested in sharing that clinical expertise because you don't have to reinvent the wheel for this type of laser and treatment. I do have several things that I've kind of discovered along the way. So my financial disclosures, I am a consultant for Erchonia, as well as podiatry, content connection, and total ancillary. The lecture goals today are to talk about a little bit of the science governing low-level laser therapy. Also to discuss Erchonia's FDA-cleared Lunula Laser for treating onychomycosis. And number 3 is the treatment protocol timeline from start to finish. And that should pretty much cover from soup to nuts everything you need to know. I always like to understand the science behind what I'm employing in my office. Obviously, our reputation as medical practitioners is paramount. And protecting it is equally important. Once you lose your reputation, it's very difficult to get it back. So how do we garner our reputation today? We have the social media outlets that can kind of have a good pulse on how our patients feel about us. So we don't necessarily want to put things into practice that don't work, because that's not going to be very good for our patients or our number one, but not good for our reputation as well. So you need to understand the science. And when I walk through the halls of an exhibit, I always want to see what is next in terms of treatment options out there. Regenerative medicine is that next avenue for medicine. During the COVID era, at least in the United States, for a while, all of our operating rooms were shut down for elective surgeries. Only emergency surgeries, things that were not elective, were allowed to proceed. So under those constraints, we needed to really push what we have in the office to its limits, and things will emerge out of something bad like a pandemic. And it's these alternate ways that we have to treat patients, whether it's a laser for nail fungus or a laser for heel pain. There are a lot of new treatments out there that don't require surgery. And as a board certified surgeon, I kind of am putting myself out of business as a surgeon, but that's okay because there's plenty of patients that still need surgery. There's plenty of patients that don't want to proceed with surgery. They just want to be treated kind of holistically to stimulate their system to heal up. So why laser for onychomycosis? Our real staples in the US are topicals that can be prescription, pills that can be prescription, or laser that's cleared by our FDA. And with those three treatments in mind, we have to talk percentages with our patients. We want them to completely understand how and set the expectation for each of those treatment options. I always say topicals are going to work about 20% and pills and laser about 75 to 85%, depending on the severity. So why laser for onychomycosis? Because it works. And I've seen the science, and we'll talk about the mechanism of action. Pills don't always work. Have you ever prescribed Lamisil and had someone take it for 90 days and they just don't grow out clear nails? And this is a patient you probably cultured and have demonstrated there is fungus. We just sometimes don't know why the body is resistant to these antifungal medications, but it doesn't stop us from trying. And again, we're not promising 100% clearance when we put patients on topicals or pills. So we need to set the expectation with laser as well. It's not to say that it doesn't work, but there's different variants of nail fungus. We have mild, we have superficial types. We also have total dystrophic. Patient that comes in with total dystrophic of 10 nails, I'm going to set the expectations a little bit differently than someone that comes in with a mild nail infection. We also know that there are things that can mimic nail infection, like lichen planus, psoriatic nails. Also, traumatic injury to nails can change the way the nail grows forever without a fungal component. So perhaps we don't see clearance in a fungal nail with Lamisil because we're having them take the medication, but the nail has been traumatized prior, so it's only going to appear still fungal, but the fungal elements might be destroyed. So we always have to kind of ask our patients in the history, have they had an issue with trauma or injury? Patients also don't want to take pills. In this day and age, patients are very holistic. They don't want to be on pills long-term, whether it's for painful conditions or for fungal infections. And this starts to resonate. You start to begin with a groundswell of patients that don't want to take pills and they're looking for other treatment options. These are the ones you're going to kind of start to identify that want to pursue laser therapy. Some patients can't take pills. They're on so many other medications that interact with their liver, or their liver functions may be out of line and they may not be able to take pills. We need other treatment options for them: alcoholism, other issues with the liver, like hepatitis can prohibit us from prescribing those pills. We still need to be able to treat these conditions without prescribing. High tech resonates with many. In my practice, I see a lot of young people and they like high tech. They find me, I ask every patient, how'd you find us? On the internet, I Google searched you. So they're always aware of the newest and the latest and the greatest. And there's a lot of information and misinformation on the internet. But it's important to be able to apply the technology in our office, not just to folks that want to take prescriptions covered by their insurance, but to be able to go outside the box a little bit and use high-tech lasers. It's a painless treatment with no side effects. That resonates with patients. They know that getting COVID could alter their sense of taste and smell. Pills can do that as well, and I've seen it in my practice. It can also alter their blood work, their white counts. It can elevate their AST and ALT. So patients are looking for things to cure their conditions without any side effects. And again, with laser, there's no interaction with the medications or liver function, as I just mentioned. So this cold laser therapy, let's just set some ground terms. It's also known as low-level laser therapy. And it's a branch of medicine that uses light-emitting diodes. Other names include low-power laser, soft laser, cold laser, biostimulation laser, therapeutic laser, and laser acupuncture. The range on the electromagnetic spectrum is 600 to 980 nanometers. So we always talk about lasers. They're, we see them in movies and things, and big destructive lasers that help, destroy cities and things. But for the most part, lasers in the medical world have been really date back to Einstein. They're light emitting amplification light rays that are exhibiting coherent patterns, meaning it's parallel and in the same wavelength. And again, this dates back to Einstein, and we're finding new ways to use lasers in the medical field. When we compare a light bulb on the left, you see multiple wavelengths of light in a divergent manner. So that's multiple wavelengths, not converging, but in a divergent manner. On the right, we see laser waves that are monochromatic, meaning one wavelength, and they are coherent, meaning going in the same direction and non-divergent. So that's the difference between a normal light and a laser light. In the US, we have an American National Standards Institute, which has set a laser classification to help us protect our patients. They label this type of hazards based on class 1 through class 4 lasers. Class 1 is the most safe, where you have minimal eye and skin protection, where class 4 are thermal lasers, where you have to really watch the amount of exposure to the skin and eyes with scatter radiation. Obviously, you need to have protection against with glasses for class 4. The laser we're going to talk about today is a class 2. And although you don't by definition have to use eye protection, we do it anyway to give the laser the respect that it deserves. And we want to protect our patients when they're in our treatment room. So having confidence in the science. When I walk the halls of a conference and different companies are pushing their latest and greatest products, my first question is, well, what kind of research have you done? Because I don't want my patients to be the guinea pigs where we're not sure if a device works or not. And then when they are unhappy and leave bad and negative comments on our Facebook and other social media platforms, it kind of affects our reputation. So I need to go in with as much material to know that this thing is working and it's been done and proven in IRB studies. So we have something called a PMN, which is a pre-market notification. It's our 510K clearance. And what happens is a company will submit an application for a PMN to the FDA. The FDA then has 90 days to label this as safe or not and classify it into one of 3 categories, not the laser classification I just showed you before for safety, but a different. And then they'll issue their ruling. Once approved, the company can go to market with their product. And that's what we want. We want to be able to know that this has been 510K cleared by the FDA, deemed safe and indicated for the condition we're treating. We don't want to start advertising in this type of device in our office if we don't have this, because our state board and society can clamp down on the advertising as well as what we're saying if there's no backing to it. A little bit about Erchonia Corporation that brings us this novel treatment. Erchonia was founded in 1996 as a small family business that's grown into an international enterprise. Their commitment to the advancement of low-level laser therapy through clinical and scientific research has transformed Erchonia into a world leader in this field. As a manufacturer, they maintain their quality production standards by operating on 85% self-reliance. They're involved with every facet of the production, design, creation, clinical testing, assembly, and marketing, which is all maintained in-house. As marketers, they hold on to the highest customer service standards possible, providing multimedia training and meeting all their clients' requests with creativity and a purpose. By overseeing the development of these specialized lasers, they've cultivated a unique market niche and are determined to maintain their status as industry leaders in the field of low-level laser therapy. And they're out of Melbourne, Florida. So what can we do with low-level laser therapy? In the center here, I don't know if you can see my arrow or not, but the laser emitter is held about 4 inches parallel to the skin. The energy is absorbed in the skin. And as we rotate around in a clockwise fashion, you can start to see all the areas of the body that a laser can be affecting. It can definitely decrease inflammation and swelling. So there's a market for this with postoperative healing, nerve regeneration, cartilage production, bone formation, enhancing muscle regeneration while decreasing atrophy, enhanced collagen production, as well as angiogenesis and neovascularization. All these properties help stimulate the immune system in fighting either an inflammatory condition or a fungal infection. So when we look at the clinical applications of low-level laser therapy, we have our acute conditions like plantar fasciitis, Achilles tendonitis. And although we're going to be centralizing and focusing just on antifungal properties, these are all the different properties that these low-level lasers have demonstrated and have 510K clearance. So you have your inflammatory conditions, you have your chronic conditions like osteoarthritis, you have a whole host of neurologic conditions like complex regional pain syndrome, entrapment and peripheral neuropathy. I've helped my diabetics with a similar laser that have had painful neuropathy. And I put eradicate dermatophyte infections in blue because we tend to think only pills can really eradicate an infection, but that's not the case here. We have actual proof that a laser will help eradicate an infection in onychomycosis. The biological effects of coherent laser radiation on cells is termed photobiomodulation, and this is the mechanism of action we're speaking of. All light is radiant energy measured in discrete units, and its effects on biological markers is mediated, two of which are cytochrome C oxidase found in the plasma membrane, found in the mitochondria, and porphyrins found in the plasma membrane of cells. Photoactivation of these two cellular elements leads to a signal cascade, which ultimately results in increased intracellular energy, or ATP, altered membrane permeability, and altered gene expression through the modulation of DNA transcription. Although the exact mechanism is still a bit unclear, all of these changes lead to physiologic changes of decreased inflammation, enhanced function, as well as that antifungal property, which we'll get into in a minute. So now that we've talked a little bit about the science, we're going to head into the Lunula Laser specifically. Why are we treating onychomycosis? We don't really need to advertise it. It's probably the most common thing we see in our practice, although we shudder to think that every patient that comes in, we have to treat. It's really something we should start treating because we're the only ones that really have credence to it, and also want to help our patients with that. When a patient goes into their medical doctor, they rarely take their socks off. They don't get their feet examined, especially diabetics. You don't really need to look for this. You don't need to advertise it. It's always coming into your office. And now that you have a great way to treat it, it's a great idea to start approaching your patient about it. Cutaneous infections are usually concurrent about 30% of the time when you document onychomycosis. So it's important to get a skin infection under control before you begin laser therapy or oral therapy for nail fungus. The reason being is we don't want the skin to seed that nail infection. Laser will treat the nails. It'll also treat the skin around the nails. But if they have an active tinea in the arch of the foot, that the bottom of the foot is not receiving laser treatment, you don't want that to be a constant source. So if someone comes in with an active tinea and nail infection, I will put them on a topical cream for about 3 to 4 weeks, get the skin condition controlled, and then we'll proceed on to the nail infection. And we will see many reasons why patients will come into our office seeking treatment. Vanity, probably being number one. Pain. I work in a very blue-collar town. A lot of people wearing composite toe type boots where they have a steel toe box or composite, and it becomes very painful when that uncompressible toe box puts pressure on a thick nail and someone's walking on it 8 to 10 hours a day. So the main causes of onychomycosis, a little bit of history with the microbiology, is that dermatophytes cause 90% of these infections, principally T. rubrum and T. interdigitale, and also yeasts and non-dermatophytic molds. Diagnosis of onychomycosis. If I'm going to pursue putting someone on a pill for 90 days or a topical that could be hundreds of dollars, or even laser therapy, I want to make sure we exactly know what we're dealing with. Someone that comes in with nail infection, 9 times out of 10 is going to have an onychomycosis. I take a clipping on every one of them. Why? Because I send it to a pathologist. I'm not sure what the standard is in Australia, but here I really want to have that document from a dermatopathologist to say that there is a nail infection here, and it tests positive, whether they're using KOH, periodic acid shift staining, or the newer PCR type detection systems or tests. I want to know exactly that we have onychomycosis, and they can even tell you which organisms you're dealing with. This document gives me proof that, okay, we're putting Mrs. Smith on Lamisil, or we're initiating laser therapy on Mr. Jones, and we know why. So if it ever comes back that they are getting great results or fair results, we want to be able to say to them with certainty, well, we know what we had because we definitely tested you. I know plenty of clinicians that don't take the time to do it, and it kind of gets them burned because the patient will be like, well, why didn't you ever test it? And it just makes us look silly. We have the means to do it. Take the 2 minutes to clip the nail and put it in the baggie and send it off, so we can help discern this condition from other conditions like psoriatic nails or lichen planus or a contact dermatitis. Also, a traumatic injured nail that we've discussed before can mimic a nail fungus, and you don't want to put someone on pills or laser and really not know what's going on. It kind of doesn't bode well for our clinical expertise. So why should we think about laser versus pills? If you look at this, this is the gamut of oral drugs that we use, the length of the treatment, and the mycological cure rates. What's striking is the amount of time the patients have to be on these pills with such a low mycological cure rate. This is the heart of the issue, is that a lot of these pills can be tough on the system, and we're not getting the results that warrant putting patients on 6, 7, 8, even 10 weeks of therapies here. So the side effects of the orals, as we know, can be hepatotoxic. We can have taste and smell disturbances. Look, a couple years ago, nobody even heard of taste and smell disturbances with Lamisil, much less a pandemic like COVID, which can mimic that as well. So it's important to obviously discuss the potential side effects of putting patients on oral therapy. In rarer cases, it can affect blood work and cause hypersensitivity reactions in the skin, as well as some depressive issues with some patients. So the answer to all these negative side effects is the Lunula Laser, which is brought to us by Erchonia. It's a 22-pound, almost a little bit bigger than a toaster oven size unit. It has a key, if you can see my arrow, it has a key switch here. So when you're not in your clinic or office, you can lock it and nobody can use it. The door in the front is magnetically sealed. It kind of pops down. Patients sit in a recumbent chair and they put their foot in, 1 foot at a time. You can't put both in, and then you turn it on. There's a software package that loads quickly on the screen, kind of like an iPad, and you turn it on and then leave the room. I actually have 2 of these because I was working with one of the clinical trials. So I'll have the patient put 1 foot in one and one in the other, and I turn it on. The treatment is about 12 minutes, which we'll go over in a minute. And then I leave the room and I have a timer on the outside of the room that I set for 12 minutes. And after the 12 minutes, their treatment's done. My medical assistant goes in and brings them out and then takes them out of the room. So there's no excessive time or anything. We kind of got it down to a science. This is the actual 510(k) clearance letter, which was issued by the FDA. This device is indicated for the temporary increase of clear nail in patients with onychomycosis. This was achieved June 13th, 2016, so almost 5 years ago. And this can be found on the FDA website. This is the document that I have, and I show my patients that the FDA has looked at this device, deemed it safe and effective for the temporary clearance. Why temporary? Because they can't ever say that a laser would permanently make the nail completely healthy. I explain it to my patients by saying, when you get sick and go to the doctor, they give you an antibiotic. That antibiotic gets you better, but it doesn't prevent you from ever getting sick again. So you always have to be true and honest and say, we can get the nails looking better, but if they keep putting their foot in a moist environment, the tendency can be for them to reinfect their toes. What you'll see here is in the center is 2 different laser beams. The more transverse one is the purple or 405 wavelength, and the 635 wavelength, which is red, is also kind of encircling the patient. This is a patented line diode that kind of rotates. So when they put their foot in, I make sure it's in the center. They're sit in a comfortable position and they hold their feet still, and the lasers rotate around their toes. I'll talk to you about the surface area that it actually covers, which is a lot greater than a lot of the other handheld type lasers. So characteristics of the 635 wavelength: it accelerates cell growth and tissue repair, accelerates fibroblasts and collagen production for faster wound healing, reduces inflammation, reduces scar tissue formation, and helps as an analgesic. Why do we need all these properties? We're healing up an infection. Sometimes with infection, you're going to have disruption of the skin. You're going to have some scarring. You're definitely going to have inflammation when this thing rubs in a toe all day. And this laser is very good at help stimulating the immune system to help fight this infection. There's also a hyperemic effect or angiogenic effect and neurogenic effect, which can help in other conditions like neuropathy. But for the angiogenesis, it's great to bring more blood flow down to this area to help heal up the infection that's caused them to have such a discolored nail. So this whole thing creates a cascade of physiologic effects, which we detailed on a prior slide. It's the 405 wavelength, however, that is actually the mechanism of action that will help destroy the fungus. The 405 wavelength, it's that purple bluish type laser, provides an antifungal treatment, antibacterial, as well as antimicrobial. This laser will help enhance the activity of reactive oxygen species in the cell. Reactive oxygen species, or ROS, helps stimulate the release of an enzyme called superoxide dismutase. This helps cause lipid peroxidation. Lipid peroxidation helps degrade the phospholipid membrane of the fungal cell and ultimately results in the lysis of that fungal cell. This is the key mechanism of action. Just as I spoke about photobiomodulation before, this is the mechanism of action you need to understand and how it destroys the fungal cell and only the fungal cell. So we have the advantages of the dual diode. They've actually included both the 635 and the 405 to help stimulate the immune response as well as destroy the fungal cells. What's left is healthy tissue and healthy matrix to develop a new nail free of the infection. So the treatment regimen for onychomycosis is basically one treatment a week for 4 weeks. I have the patient come in after they've decided to proceed. They come in, we laser each foot for 12 minutes, and then they're free to go home. They're going to continue to follow preventive measures at home that we give them on a list. I can provide Harish with my personal consent form, as well as the list of 12 items that they can do at home, like keeping their bathtub scrubbed with bleach, putting clean, dry socks on every day. If they sweat a lot, to make sure their shoes are clean and dry. After those 4 weeks, they've been treated 4 times. I have them come back 6 weeks later. After 6 weeks, I'll maybe give them another treatment or 2, depending on how they look. And that's how we proceed. I've lasered someone probably up to 10 to 12 times. It's no sweat off my back. I want to make sure the patient understands we're going to do everything we can. By 6 weeks, you start to see that clear growth. And if you document it day 1, you can document which nails are improving and which aren't. In terms of debridement, this laser is not, you don't have to debride the nail prior to treatment, but my opinion is very strong. And I really feel like you need to debride the nail heavily on the 1st and the 4th treatment. I treat them on day 1 and debride every fungal nail as thin as I can go without kind of taking it down to the nail bed. Why? Because the less fungus on the toenail itself is less fungus I have to kill. The laser, I feel, works better with a thinner nail. Obviously, laser penetration through a nail has to be measured, and it's going to be a good idea to thicken or to thin out those real thick fungal nails so you can get the laser to go through. I don't debride the nail on the 2nd or 3rd visit because the nail really hasn't grown much between the 1st and 2nd and 3rd treatments. But by the 4th week, I'll actually debride the nails again and then treat them a 4th time. I also give them something called a steri shoe, and I'll get more into that in a bit. These are pre and post treatments. These are not mine, but I'll show you one of mine at the end after 6 months. So here you can see, looks like total dystrophic. And after 6 months, you're left with just distal subungual or distal lateral. And here again, you can see these. We can send all these studies to you and all the pre and post laser pictures. When I explain this to my patient, I always explain it as mild, moderate, or severe. Why? Because I know whether an infection is severe or not. They don't understand. If their infection is mild or moderate, I explain that with laser, they'll get really great results. If it's total dystrophic times 10 nails, I temper the expectation because I never promise anything. I always talk to them about what we know works, whether it's Lamisil, topicals, or laser. You have to set the expectation accurately with your patients so there's nothing that they're walking away feeling like you promised them that it's going to completely turn into a healthy new nail. If there's prior traumatic injury, that may be affecting the overall results. So the FDA timeline and the clinical results. From first submission to final approval took about 7 years. It's been a thoroughly researched laser with 1 pilot study, 3 level 1 IRB approved clinical trials conducted in the US and in Europe. This study showed basically that after 6 months, there was 133% increase in clear nail growth, going from 4.6 millimeters out to 10.75 at 6 months. So definitely showing clear nail as evidenced through photography as well as mycological cultures. So this slide is really good because it demonstrates, I'm going to try and move There we are. This is going to demonstrate a comparison of the Lunula laser, which operates at the 635-405 with the other thermal lasers. This is a non-thermal laser. You can use this on patients that are diabetic, that have neuropathy, patients that have poor circulation, patients that have very brittle, thin skin. You're never going to burn them. They're never going to have to tell you, ouch, something is burning or feels bad, because there's no heat to feel. In fact, most patients have to be explained to that it is working even though they don't feel it. They sometimes feel like they have to feel pain in order to get results. Other laser devices are thermal and they can be very hot, and you have to heat up the nail to a certain degree. And if they don't tolerate it well, this patient may not get optimum results because you can't take them to the level that fungal lysis occurs. And when it says no required debridement of nails, that is true. However, I do recommend strongly to do it. The treatment or spot size for another laser like the stylus type lasers are 2 to 10 millimeter spot size. This is not a typo, but the treatment size for the Lunula is 28.62 centimeters squared, because you have such a large swath of the dual laser. It completely covers the forefoot. I've never had a patient that I needed to kind of treat the right side of the foot and then the left due to the size of the foot. That laser rotating in that whole compartment gets the entire forefoot covered. The treatment time is 12 minutes for all 5 toes, where it's 4.5 to 5 minutes per toenail on the other thermal lasers. The other key here is that this is automated. I set it and leave. I don't have to pay attention to how, where I've been on a nail to know that it's been eradicated. Whether you're using a thermal laser or a Lunula laser, the entire nail bed is going to look, or the whole nail plate will look no different after treatment versus prior to treatment. So you're never going to know if you missed an area. This is a great slide that talks about surface area discrepancy. On the right side, those little circles demonstrate a 2 to 10 millimeter spot size, where you're kind of going point by point on the nail plate. If you miss an area, you'll never know it. And if the heat does not eradicate or lyse that fungal cell, you may not be able to get full eradication. And if the patient is in pain, you're not going to be able to get it up to 107 degrees. On the Lunula side, on the left, all the purple area is the area that's treated by the laser. The periungual area, the hyponychia, and the subungual area, as well as the nail plate and the eponychium, are all treated with the Lunula. We'll take a brief look at the laser now. So treatment protocol timeline, we've talked a lot about the science of the laser and what the laser does and how you can protect your patients. They also do give you goggles so the patient can be wearing them. The timeline is, I see an initial evaluation. Someone comes in today with nail fungus and they want to get rid of it. I'll take a clipping for a culture, whether they want to pursue treatment or not. Sometimes learning that it is a cultured fungus will kind of push patients in the direction of treating it in some way. And then the expectation is that I'm going to discuss with them the 3 treatment options on day 1. I really don't push patients in any of the 3 ways that we can treat them, topicals, laser, or Lamisil, because I want them to make that decision. And I'm there just to provide the information about cost, because in the US, laser is not covered by insurance. But I also talk about pills and side effects and the diligence that they have to have if they're going to use topicals. So the initial evaluation, I take the clipping, I say, these are the 3 treatment options. Here's a brochure on laser. Here are the other brochures on Lamisil as well as topicals. It'll take about 10 days, Mrs. Smith, to get the results back, and we're going to call you and you'll let us know how you'd like to proceed. I have all these types of treatments updated on my website, so when I give them a brochure, they can refer back to my website. And I know Harish can supply you with some of the videos that Erchonia provides to help with the marketing and help your patients have information that they can leave with so they can read about it. Because I always like to be able to read things at home about treatment options, discuss it with family members. or my medical doctor. So then I discuss those 3 treatment options. I'm going to call the patients after 10 days with the results. And then if they decide to move forward with laser, they're going to come in. We'll set up a laser appointment. We go over the consent form on that day. I will debride the nails heavily on the 1st and 4th again, and then we start the treatment. I'll also give them a list of everything that they can do at home. I'll provide this to Harish as well, including using a Steri shoe, which is an ultraviolet shoe sterilizer. Very important to set the responsibility on the patient that once treatment's done, they have a job to do at home, and it's to keep their feet clean and dry and to not keep putting their foot in the atmosphere that kind of created the situation. Otherwise, in a year, they could be right back where they are. And many times when patients come back after a year, it doesn't happen often, but I'll say, well, did you stop sterilizing your shoes? Did you stop putting powder in your shoes? Did you let your shoes breathe? Because I know you work in that wet, moist environment, and they'll invariably will say, no, they kind of dropped the ball and they reacquired the infection. So we're going to, again, once a week treatments for 4 weeks, and we have them come back after 6 weeks, and then we'll laser them 2 to 3 additional times and debride them as well. I will finally discharge them once that nail's grown out at about a year. This is the shoe zap or Steri shoe that I was talking about a minute ago. Very good because it kind of allows them to keep their shoes clean as well as their family's shoes. This is one anecdotal type of patient that I've kind of developed a way to treat. This patient came in with the beach on him. I know you guys have beach down there. He came in with sandals and he had sand on his feet, and he was like a 30-something gentleman who wanted me to take all his nails off because he was so embarrassed to wear sandals in the summer. I said to him, and if you look down the barrel of this toe, you could probably see all the way back to the eponychium. And the reason he wanted to have him removed is due to vanity and embarrassment. I said to him, let's do this. Let's surgically remove the nail. We numbed up the toe. We took the whole nail plate off, and then we allowed the nail bed to heal up. So we didn't use phenol. This was not a permanent matrixectomy. We just did a total nail avulsion, allowed the nail bed to heal. And I said, let's treat the nail bed with the laser for 4 times, because this is one of those total dystrophics. It looks like it had been traumatized and stomped on. I said, this is a great last effort. If this doesn't work in 6 months, we can definitely do the phenol and kind of prevent your nail. But he was in his 30s, and I didn't want to do that to him. You can have vanity issues without toenails just as much as you can with a fungal infection. And this is what after 4 months or 6 months, I'm sorry, looked like. Even the second toenail kind of cleared up. He has a disappearing nail bed syndrome at the end. So when you look back to that prior nail, the distal part of that nail is not adhered down to the nail bed. So he can live with that. This will grow out another 2 to 3 millimeters. But after 6 months, I basically, and with the laser, restored his nail. This is tightly adhered down, and he was thrilled with the results. Now, the trauma from that nail fungus in so many years caused that nail to never be able to re-adhere down to the nail bed. But down here it is. And if it grows out another 2 to 3 millimeters, he has a fully functional nail that'll cause no embarrassment. And he was thrilled with it. So this is the type of procedure you can do with this laser only. You cannot do this with a thermal laser, because with a thermal laser, it's going to create too much pain, and you could burn the nail bed and cause dystrophy and traumatize that nail bed and matrix with a laser. But with a non-thermal laser, you can certainly do this. And I've done this several times since. In fact, I now target the total dystrophic nails and say, all right, we get better results when we do a nail avulsion. So you build a procedure for the nail avulsion, have them come back after a couple of weeks and the nail bed's healthy, and then you laser them 4 to 6 times, and you can see how you can change someone's life. So I know we kind of shot through a lot of slides here, and we're right at that 40-minute mark. I'm glad to have been asked to discuss and talk to you about how I've incorporated this laser into my practice. I'm going to turn it back to Harish. He can he can read over the questions if there are any, and I'm available for as long as you guys need me, because I want to be able to answer the questions, and he'll be able to provide my email address. You can contact me directly, and when I wake up after you email me, I'll be sure to answer your questions.
Thanks, Richard. I've got a few questions which I can read it to you.
Sure.
The first question is there any new published evidence showing the efficacy of this treatment?
We can show you all the published studies that were carried out by Zhang out of Arizona. We can send you all the studies that were done. I don't know of any recent ones. I know Erchonia is going to go for mycological cure. I don't think they've achieved that yet, because I think COVID has slowed a lot of things down. But there are a lot of good studies out there that demonstrate that this laser is mycologically curing the nail.
Right. The next question is, where can we purchase the measuring device for objective evaluation when taking photos?
There is a program that I can refer you to. The name escapes me right now, but it allows you to take a picture of with your iPhone, and we can get that to you. You put me on the spot with that program, but with the program, you can actually measure the clear nail growth. You basically take a picture day one, and it's in a reproducible. The camera is a few inches above the patient's toe, and then you kind of chart out where there's fungus, and each time they come in, you can take another picture and align it and calculate the millimeters of growth.
Okay, thank you. The next question is, we use TGA in Australia. Is this similar standard than the FDA?
Well, the FDA is our body that would classify this as a medical device and allows us to use it in a medical setting. This cannot be done in a spa. Has to be done by a physician who's trained to be able to treat this. So I would, if Harish, what you're telling me prior, this is your governing body, then it would be the equivalent of the FDA. There's no higher authority in the US. Once we get FDA clearance, then we're able to take it to market and use it in our office.
Great. Thanks, Richard. The next question is, do you ever do more than 1 12-minute sessions per appointment, focusing on different digits? For example, on the first and then third digit?
Well, the laser beam rotates. So if you think about a line that rotates, whether you're in the center of that rotation or on the edge, you're still getting the same amount of radiation, if you think about it. So as long as the foot is centered in that, in the center of the plate, 12 minutes is enough. I've never needed to do more. You're never going to see a difference pre and post treatment. You only see a difference after 4 to 6 weeks. So for a patient, whether they have 5 nails on one foot and the other foot is completely clean, I always use the laser on both feet because I want to kill infection even when the nail hasn't changed. Some studies show that early nail infections will show clear nails, but they do test positive. So I want to treat both feet, and I don't treat more than 12 minutes per foot at a time.
Thanks, Richard. The next one, can ladies apply nail polish after a Lunula treatment?
If somebody's coming in with an infection, a lot of the nail treatments today with gel nails and other types of adhesives are very thick. They don't allow a lot of breathing on the nail. So while we're treating actively, I don't recommend use of nail polish. And even after we've cleared their nails, I will tell them to put nail polish on, but to remove it once every 2 weeks, because you don't want to leave it on for 4 or 5 weeks because the airflow under the nail is minimal and they can kind of develop an infection again. So they are able to use it. I usually just don't like to use it within 6 months of starting treatment because I really want to give those nails a lot of air and as well as the ability to grow out.
Thanks, Richard. The next one is, have you had many failures using Lunula?
There are some failures, and what I have to do is really be honest with the patient. If they come in with one of those nails like I just showed you that you know something is stomped on it, it's not a mild infection, it's severe, you need to set the expectation accurately with a patient. When I do surgery, and I don't ever promise someone that a bunion won't return or that they won't have a complication or break a screw or develop an infection. They're all rare occurrences, but I have everyone sign a consent saying they acknowledge that these things can happen. It's no different with a benign laser that you're treating for nail fungus. The patient has an expectation. You have a more realistic expectation because you're the doctor. You need to kind of equate those together and make sure you're on the same page. Someone that's coming in looking to change 10 totally dystrophic nails into completely healthy, I will probably try and talk them out of using laser. And if they're hell-bent on using it, I'll say we need to proceed cautiously because I'm not guaranteeing that this is going to be completely cured. And I've, again, treated patients up to 10 to 12 times. If I'm not at the results that I want, I may add on the Lamisil or topicals, but typically I don't mix treatments. And there are failures, but again, not everyone's coming in with total dystrophic. Superficial onycho, they're doing great. Distal subungual, they're doing great. But when it's total dystrophic, you have to ask in the history, do you have a history of trauma? Because there's nothing that's going to repair those matrix cells if they've been damaged prior. We can get rid of the infection, but the nail may just not look normal. And that's okay, as long as they're aware of that at the get-go.
Okay. Any more questions, people? If you can just type it up, or at this stage, there's nothing. Do you want to say last few words, Richard, before we wrap up?
Sure. I know Harris will supply you with my cell number. If you can figure out how to call me, I don't know how to call Australia, but you can certainly email me and I will respond quickly. If you have clinical questions, there's no real need to reinvent the wheel. We can provide a consent form for you and a list of things. And patients like it that, in the US, they have to pay out of pocket for this treatment. So I want to send them home with something that can help them. They only come to us 4 to 6 times, but they're in their home every day. So giving them the Shoe Zap or the Steri Shoe is a real great tool for them to help prevent reinfection. And they appreciate us giving that back to them. So if you have any questions, reach out. It's a great laser. I've been using it for 4 years. I purchased mine. I wasn't given mine. And I haven't found any laser to date that I would replace it with. So I'm real happy with the results.
Okay, there's a couple of more questions turn up.
Sure.
I'll read it to you.
No problem.
Do you use any topicals to help get the nail bed healthy up, particularly when there is a dystrophy to the nail bed, like serum or similar?
What I will do on the list of things that I can have the patient do at home, like keeping clean and powder and changing socks, I tell them to buy Lotrimin AF spray. It's one of our topical sprays. It's a powder-based spray. And I tell them to use that every day just to keep fungus off their toes. It's a good preventive. And that's what I have them use. Sometimes when you put on the oily type topicals, it can affect the dispersion of the laser. So I would never have them do that while you're actively treating them, because we don't want to alter the effect of the absorption of the laser or disperse the laser. But ongoing after treatment, I usually have them buy Lotrimin AF, which is an over-the-counter, good topical antifungal spray.
This question, I think, relates to the previous one, further to what I said, or just antifungal topical to stop getting fungus getting in between their treatments.
Again, if there's a skin infection, you need to treat that prior to initiating nail treatment. I don't want the skin to keep feeding the infection in the nail. So I'll have them apply a topical, and I usually don't go with over the counter. I'll prescribe a prescription antifungal cream that will be applied topically once a day, rub it into the skin till you don't see it or feel it. And that goes on all the red scaly area of both feet. Once I've established that skin infection is eradicated, I can proceed with the nail laser. And that usually pretty much takes care of anything that's going on the foot. I don't like to do a lot of topicals while we're using the laser because it's effective itself.
Thanks, Richard. Another question is out of interest. What's the charge out fees in US dollars?
So I basically, there are people that will charge per toe. I look at what we're doing. This laser is very expensive. And we don't usually love to discuss numbers, but I charge $1,000. And what I say to my patient is, if you're going to subscribe to this, then we're going to laser you as many times as we need to. There's never an upcharge. There's never another charge. If I have to only treat them 4 times or 12, I don't charge them a penny more. The other thing I would recommend is to collect it all up front. This isn't just for our own well-being. It's really to see the commitment on the patient's part, because if they have to pay you like every week, let's say they get a big credit card bill at week 3, and then they decide, you know what, I can't afford it, so I'm not going to go in. Well, when they don't get that 4th or 3rd treatment and then it's delayed, I don't want their results to be affected by their situation. When you collect up front, and we don't mean to discuss business, but it's only good policy that once they've paid, they want to get their treatment. And it really kind of sets the tone for their responsibility. When you have to pay per session, every time they have to pay you, it's becoming a thing in their head. And I've seen this where they can't come in because they have a car payment or something, and then it just gets pushed aside. And then we have to kind of say, well, you didn't have the prescribed treatment 4 times in a row, and we don't know if that affected it or not, or they don't come back for 2 to 3 weeks. So I always recommend trying to collect it up front. It makes for a much more attentive patient in meeting their obligation of coming in when they're supposed to.
Thank you, Richard. Another question is, can we get a copy of this presentation?
Absolutely. There's nothing proprietary in it, just my my love of PowerPoint. But I'll give Harish a copy of the presentation. You can certainly take it and read over it. There's a lot of good information, as well as articles at the end that detail the studies somebody had asked about.
Thanks, Richard. It appears to be a last question. It says, do you change your approach when explaining the effectiveness of the laser for a patient with superficial mycosis or severe mycosis, dystrophic thickened nail?
So I will offer laser. The laser is indicated for anyone with nail fungus. Okay, so that's the whole gamut. It could be superficial, it could be total dystrophic. The only thing I change or discern is how I approach them with the expectation. If it's a superficial or a distal subungual, and it's not affecting the whole nail bed or back to where the matrix is, I think the results are going to be outstanding and really great. And I tell them that. When it's total dystrophic, I temper the expectation. I may say, Mrs. Smith, your left first toe is so thick, I really can't predict how it's going to look after treatment, but all your other nails are mildly infected. So that's what patients understand. They understand mild, they understand moderate, they understand severe. That's the terms that I explain to them so they can understand. When they know that they have a mixture of mild and severe, they know that they may get mixed results with the laser. If it's only a mild infection in a couple toes, they know that they're going to get great results. And if it's really moderate or severe in all the nails, I kind of temper that expectation just so there's no disappointment in 6 to 9 months. But I will treat older patients. I'll treat younger patients. Patients that are under 18 that we can't put on Lamisil are great candidates for laser therapy. Diabetic patients that are on a million medications, or patients that have poor circulation, are good candidates for laser therapy, because you don't have to worry about interacting with the liver or them being burned on their brittle skin.
Okay, I've got another question from our New Zealand friend. We have had a laser in Queenstown, New Zealand for 2 years and see some really good results. I like what you are doing with the cost treatment protocol. We have often offered extra session at no charge. I know that there are so many different presentations, and in some cases have pushed out to 8 treatments in some. With the return a few months later, we have done another course again. How far out have you gone with treatment protocols before you give up?
Well, I always tell my patients I'll never give up, because I will switch modalities. Look, nothing is a magic bullet. I never say this laser is the only thing. I equate it similar to Lamisil at 75 to 85%, depending on severity. So I will treat them 4 times. I've gone up to 10 to 12 times. And if I can sense that the patient's still unhappy or they still want to try, I'll recommend putting them on Lamisil. This is just the nature of what this is. If they're paying out of pocket, it's no less, important to get the result that we need. It's actually more important because they're paying. So I always tell them that we're going to try laser. We could also add Lamisil if they want. Most patients don't want to initially. And if we need to, we put them on the pills. The goal is to get them better, no matter what treatment we offer. If you're completely honest, they will respect that, and they will know that you've done everything you can. We're the messengers. We know what works. We know what doesn't work. How many patients come in having spent hundreds of dollars on over-the-counter products that tout that they're going to clear up the nails, and they do nothing. We are the benefactors of the information that gets them to where they need to go. We just need to be honest about it, explain all the situation, and let the patient kind of guide us. But I will certainly switch modalities, and there are failures. Is it everyone? Certainly not. But a total dystrophic is going to be a very tough case. That's why you can try a nail avulsion like I did. These are the ways that your patients are really going to remember you, because you've thought outside the box and how you can treat them differently than the neighbor or the colleague up the street who has a thermal laser that really hurts. And we've seen plenty of those patients in follow-up that it was too painful and they never got the results that were promised. And we just don't promise anything. We know what works and we explain that so it's complete transparency.
Thanks, Richard. One last question, I think coming from the previous one, you may have answered part of it. The question says, how often are you combining tablets and laser at the start?
How often am I
How
combining?
often are you combining?
You mean pills and laser?
Yeah.
If the patient really is aggressive and they want, let's say they are getting married in 10 months or a year, and they want to be able to wear an open-toed sandal or a dress shoe, and they just want to hit it with everything, then we can certainly start with Lamisil and laser, depending on the patient and what time frame they're on, what they are trying to achieve. If it's just trying to thin out the nail so they can work pain-free, then it might be just a good idea to start with either one or the other. We do offer, combinations, but, most patients that start with laser probably are jumping to it because they don't want to take pills, or they enjoy drinking alcohol and their AST and ALT may be elevated. So there's many reasons, but you kind of got to just glean the what your patient wants and the goals.
Great, thanks, Richard. I think we don't have any more questions. I guess we can wrap up. Thanks again,
Sure.
Richard, for sharing your honest and knowledge on the subject of treating fingernails.
No problem.
I hope all found this session valuable. If you have any further questions, please don't hesitate to contact us. We can always get back to you with answers. We have recorded the session and we'll be sharing the link soon. Thanks again for your time and have a great day.
Take care, folks. Good luck to you. We're here for you.
Bye-bye.
Bye-bye.